Continuing on the theme of endoscopy in pancreas, I call upon the next moderators and chairpersons, Dr. Ashok Jhajaria from SMS Jaipur, Dr. Arul Prakash from SRM Chennai, Dr. Guru from University of Minnesota.
Now we will invite Dr. Vikas Singla. The talk is EUS guided cyst ablation and RFA. Dr. Vikas.
Good afternoon to all of you. I'm thankful to organizing committee for the kind invitation and the opportunity. So I have no disclosures pertaining to this presentation. So pancreatic cystic lesions, they have a neoplastic potential and they can be a precursor for the adenocarcinoma. So as of today, either surveillance for the benign lesions and surgery are the most common strategies, and both are difficult for the patient to follow. Surgery has a morbidity and surveillance requires annual imaging. And EUS guided cyst ablation is an emerging technique but confined to few centers. RFA has also some role in the solid lesions. So these are the key points which we will discuss. We will discuss indications and which agent to use, technique, and the outcome of pancreatic cystic lesion. So whenever we have a pancreatic cystic lesion, these are the broad differential diagnosis. So either it can be a benign cyst like pseudocyst or a serous cyst neoplasm, or it can be a malignant lesion, or it can be a mucinous cystic lesion without dysplasia, or it can be a indeterminate, can be either serous or mucinous. So treatment is straightforward. In the left side, they require nothing. For pseudocyst, drainage may be required. For serous, they need a follow-up. Malignant lesion, they will require surgery, but the central lesion, the treatment has to be individualized in these patients. So how we evaluate a pancreatic cyst? So first and foremost, the history. The patient has history of chronic pancreatitis, the lesion is likely pseudocyst. And MRI should be the first investigation for a pancreatic cystic lesion. Not all the patient will require EUS. Patient who had worrisome feature on MRI may require EUS. And similarly, not all patient will require the fluid aspiration. So this is how the cyst may look like on the endoscopic ultrasound or on MRI. So if it's a honeycombing appearance, it's a diagnostic of serous cyst adenoma. It doesn't require anything. And if there is a large nodule or mass formation, it indicates it's a mucinous lesion with the malignant potential. It requires surgery. So if on MRI there is a mass lesion, the patient can be sent for surgery. And first and third are the diagnostic dilemma. So if it's a unilocular cyst, it can be a pseudocyst, it can be a mucinous cyst, it can be a unilocular serous cyst adenoma. And similarly, this lesion can be either a serous cyst adenoma or it can be a mucinous cyst adenoma. So these two lesions may require aspiration, and on aspiration we send sample for amylase, CA and glucose. If the level of glucose is low, it indicates it's a mucinous cystic adenoma, cystic neoplasm. Mucinous neoplasm, they have active cell, so they will consume glucose and the glucose level will be low in these patients. So it's a bedside test can easily diagnose it's a mucinous neoplasm. CA level will be high in the mucinous cyst and amylase will be very high in patient with the pseudocyst. And the KRAS and GNS can be done. If they are positive, they suggest it's a mucinous neoplasm and there is a high risk of dysplasia in these patients. So this is a differential diagnosis in these patients. Either it can be a serous, or it can be pancreatic pseudocyst, or it can be a mucinous cystic, or it can be an indeterminate lesion. So in the studies, both indeterminate and the mucinous neoplasm has been subjected to the EUS guided ablation. So these are the indication patient who have a unilocular cyst or the oligolocular up to 4 or 6 locules, they can be subjected to the EUS guided ablation. Diameter should be more than 2 cm, larging cyst with the more than 2 cm, or diameter should be more than 3 cm for EUS guided ablation. Surgery should be offered first. If patient refuse surgery, only then the EUS guided ablation should be offered. So the patient who had a unilocular or oligolocular cyst, they can be offered EUS guided ablation. Patient who had a size less than 2 cm, it should be avoided, and patient who had a large mass, this should be avoided. And similarly, patient having bunch of grape appearance, this should be avoided as there are multiple loculi which cannot be targeted with the EUS guided ablation. So these are the various agents which has been used earlier. Alcohol was used, then paclitaxel and gemcitabine has been used. So either 19G or 22G needle is used. There is a risk of fluid leakage with the 19G needle, and sometimes it's difficult to pass in the head region. So the nitinol needle may be better in the lesion in the uncinate or in the head region. So during this technique, we aspirate the fluid So we aspirate the fluid and leave a small rim of fluid around the needle, so that needle doesn't come in contact with the cyst wall, otherwise there can be risk of hemorrhage, or needle may enter the surrounding pancreatic parenchyma. So we aspirate the cyst and we replace the volume of cyst with the chemotherapeutic agent. And in EUS we can aspirate, and if it's a bunch of grape appearance, it should be avoided. So we aspirate cyst and replace the volume with the equal volume of chemotherapeutic agent. So in aspiration we completely empty the cyst. In alcohol we use the lavage technique. So we inject alcohol in the cyst and then leave it for 3 to 5 minutes, and then we have to re-aspirate the alcohol. And in paclitaxel or gemcitabine, we have to do the infusion technique, where we infuse the cyst with the paclitaxel or gemcitabine, and there is no need of re-aspiration, they have to left in situ. So earlier studies used the alcohol with or without paclitaxel, and the efficacy was around 30 to 70%. But the right column is worrisome. There were significant serious side events like pancreatitis, splenic vein thrombosis, portal vein thrombosis. So normally it's a benign disease which requires surveillance. So these are very serious adverse events which are not acceptable to the patient. So this is a large study of 164 patients. In this study, the patient who had indeterminate or the mucinous cystic neoplasm, both the lesions were involved in the study. 164 patients, they underwent ablation with the alcohol followed by paclitaxel, and they underwent same session treatment, one session of treatment they underwent, and the median size was 3 cm. The most lesion were the mucinous, then 63 were indeterminate, and few were the serous cystic neoplasm. And we see the outcome, the complete resolution, which is defined as if there is a 95% reduction in volume of the cyst, then it's a complete resolution. So around 70% of patients, they have complete resolution with the alcohol and paclitaxel, and they were followed up for next 6 years, and out of 114, only 2 had a recurrence. So it means that patient who had a response to the alcohol injection, they have a durable response for 6 years. But many patients had a complication. Few patients had pancreatitis, pseudocyst, portal vein thrombosis, and the splenic vein thrombosis. So these are the serious complications. So it was thought that alcohol may be a culprit agent for these complications. Then came the CHARMS trial. So this trial included only the mucinous cystic neoplasm. Previous trial included serous cystic neoplasm, mucinous, and indeterminate. But the CHARMS trial included patient only with the mucinous cystic neoplasm. It was a randomized controlled trial, 39 patients. So one arm received alcohol followed by paclitaxel and the gemcitabine, and other arm alcohol was replaced with the sarin followed by the paclitaxel and the gemcitabine, only mucinous cystic neoplasm. And we can see at the end of 1 year, 67% in the alcohol group, alcohol-free group, and 60% in the alcohol group, they have a complete resolution of the cyst, which is similar. And we see the adverse event 28% in the alcohol group, and in the saline group, no patient had a complication. It means alcohol is a culprit for the complication. So only the therapeutic agent like paclitaxel and the gemcitabine, they can be used for the similar efficacy without any side effects. And these are the long-term data for the CHARM trial. We can see that patient had an initial response to the treatment. They could maintain the response over next 4 to 5 years. So treatment response is durable. So the next question is, if the patient has complete ablation, do the patient require the surveillance? The answer is yes, because these are mostly field defect. Patient can have adenocarcinoma or the new lesion at other sites, and we have limited long-term data, and we don't know the end point. Whether reduction in size or epithelial degeneration will ensure that there will be no recurrence, this cannot be said. So these patients should undergo surveillance, and as of today, we don't have any head-to-head data comparing the lesion with the surgery to advocate the one treatment over the other. So the recent Kyoto guidelines, they advocate that the ablation should only be done in the setting of clinical trials. It should not be a routine treatment. So this is, as of today, we treat the pancreatic cystic neoplasm. Patients who are symptomatic, they should be offered surgery. Asymptomatic, high risk feature, they should be offered surgery. Low risk feature, they can be under surveillance. In the future, we may offer low risk patient with the EUS guided ablation. If there is a complete resolution, there may be cure. And if there is a persistence of lesion, patient may undergo surveillance. Another procedure is the radiofrequency ablation. In this radiofrequency ablation, high frequency current is used and which generate local heat, and there is a localized coagulation necrosis. And the lesion should be around 2 mm away from the MPD, otherwise there is risk of pancreatitis. And the indications are the neuroendocrine tumor, adenocarcinoma, and the cystic neoplasm. So 2 probes are available. One is the Habib probe, and second is it can be passed through a needle. Another is the needle-based probe, 19G needle. So we go inside the lesion and ablate, and so I think it's not working. Yeah. So we go to the distal part of the lesion, then we apply the 30 to 50 watt of energy, and we see a cloud there. And in the one session, the whole lesion can be obliterated. So, and after that, the imaging should be advised, and we should look for any viable area, and the procedure can be repeated after 3 months. So these are the guidelines for treatment of non-functional NET. According to European guidelines, the lesion which is less than 2 cm, and according to the North American guidelines, lesion which is less than 1 cm, they can be followed up. But sometimes patients are not willing for the surveillance. They can be offered the EUS guided ablation. So if the lesion is more than 2 cm, surgery is treatment. Lesion less than 1 cm can be followed up. Between 1 to 2 cm, if it's a G1 lesion, low grade NET, they can be offered either surgery or a EUS guided ablation. So this is the meta-analysis of 196 patient. 101 patient had a functional lesion, mostly insulinoma, and 95 were the non-functional. And we can see that the efficacy is more than 90%, and adverse events seen in 20% of patients. And most of the patients, they require only 1 session, and there are no serious adverse event, only 1 in each group. So this is an effective treatment for the pancreatic neuroendocrine tumor. So to summarize, EUS guided cyst ablation and RFA are the emerging but the effective techniques. Mucinous lesion and the BDIPMN are the candidate for the EUS guided ablation. Size should be between 2 to 5 cm, and it should be oligonuclear. There should be 4 locules. Alcohol, paclitaxel, and the gemcitabine are the most studied agents. Alcohol-free regime, there may be reduction in the side effects, and the complete remission rate is around 70%, and the effects are maintained for the long term. And RFA is effective treatment for the pancreatic NET. Thank you for your patient hearing.